Welcome to our first video on congenital T-cell immunodeficiencies. In this lecture, we will cover DiGeorge syndrome. Let's begin. For DiGeorge syndrome, we will cover its definition, pathophysiology, risk factors, clinical features, diagnosis, and management. DiGeorge syndrome is a congenital disorder that stems from a microdeletion of chromosome 22. Specifically, a 22q11.2 microdeletion leads to abnormal development of the pharyngeal pouches, which leads to a wide range of problems. Importantly, abnormal development of the third pharyngeal pouch leads to thymic aplasia, and thymic aplasia in turn leads to T-cell deficiency. Let's utilize this figure to briefly review the embryology of pharyngeal pouches. Pharyngeal pouches are a component of the pharyngeal apparatus, along with pharyngeal clefts and arches. Each pharyngeal pouch develops into specific structures, and as mentioned on the previous slide, the third pharyngeal pouch develops into the thymus. Recall that the thymus is a primary lymphoid organ that produces mature T cells. Hence, if it is absent or defective at birth, patients will experience a lifelong T-cell immunodeficiency. When it comes to the risk factors for DiGeorge syndrome, none have been identified so far, as DiGeorge syndrome does not seem to be heritable. Rather, it arises from de novo mutation. The clinical features of DiGeorge syndrome are often remembered using the catch-22 mnemonic. The term catch stands for cleft palate, abnormal facial features such as low-set ears, or hypertelorism, thymic aplasia, cardiac defects, and hypoparathyroidism. The number 22, on the other hand, reminds us that this disorder stems from a microdeletion on chromosome 22. Let's take a moment to examine each of these clinical features in more detail. Here's an image of a baby with a cleft palate. And here's an image of a patient with hypertelorism, or widely spaced eyes. As mentioned earlier, thymic aplasia will result in T-cell deficiency, which will manifest in the form of recurrent infections, which in turn will lead to failure to thrive. Additionally, examiners want students to know that babies with thymic aplasia will have an absent thymic shadow on X-ray. Consider these two chest X-rays side by side. The chest X-ray on the left was taken from a healthy baby. Note the spine, the heart, and this opacity overlying the right upper lung that somewhat resembles a sail of a boat. This sail-like opacity is produced by the thymus. Now consider the chest X-ray on the right, which was taken from a healthy adult. Note that there are no sail-like opacities in the right upper lung. This is because the thymus normally atrophies once it's done producing mature T cells, which normally happens around puberty. As such, the presence of a thymus shadow is a normal finding in children. Therefore, absence of thymic shadow on pediatric X-ray like this would be suggestive of an abnormality like DiGeorge syndrome. When it comes to the cardiac defects seen in DiGeorge syndrome, the two most common defects are truncus arteriosus and tetralogy of Fallot. And both of these pathologies present clinically with cyanosis, that is, refractory to supplemental oxygen therapy. Let's utilize a series of images to briefly review truncus arteriosus and tetralogy of Fallot. The illustration on the left is that of a normal heart. The illustration on the right, on the other hand, is depicting truncus arteriosus, which is characterized by failure of the pulmonary trunk or artery and the aorta to separate during embryologic development. This results in ventricular septal defects and mixing of oxygenated blood from the left ventricle and deoxygenated blood from the right ventricle, which in turn results in cyanosis. Now, compare the normal heart on the left against the illustration on the right that's depicting tetralogy of Fallot. Tetralogy of Fallot is a congenital birth defect that is characterized by four key abnormalities: a stenotic pulmonary valve, an enlarged right ventricle, a ventricular septal defect, and an overriding aorta. Once again, these abnormalities allow for mixing of oxygenated blood from the left ventricle and deoxygenated blood from the right ventricle, which leads to cyanosis. Here's a chest X-ray taken from a patient with tetralogy of Fallot. Note that the cardiac silhouette somewhat looks like a boot. It isn't uncommon for the anatomic abnormalities seen in tetralogy of Fallot to give the heart a boot-shaped appearance on X-ray, and it is important to remember this fact for the boards. The last cardinal clinical feature of DiGeorge syndrome is hypoparathyroidism. It primarily manifests in the form of hypocalcemia, which can result in seizures, tetany, and arrhythmias. Now that we've covered the key clinical features of DiGeorge syndrome, let's discuss diagnosis next, which usually begins with a simple laboratory evaluation. Due to hypoparathyroidism, patients with DiGeorge syndrome will have low serum parathyroid hormone, or PTH, and as a result of low serum PTH, they will have low serum calcium as well. Due to thymic hypoplasia and the resultant T-cell deficiency, these patients will commonly have lymphopenia. In addition to basic laboratory evaluation, echocardiography is also an important part of the diagnostic workup, as it will help assess for the presence of any cardiac defects, such as truncus arteriosus or tetralogy of Fallot. Lastly, the diagnosis of DiGeorge syndrome can be confirmed with fluorescent in situ hybridization, or FISH for short. This study will help the clinician detect the 22q11 microdeletion that leads to DiGeorge syndrome. Here's a series of images depicting the results of fluorescent in situ hybridization of normal cells and cells that carry a 22q11.2 microdeletion. The red marker corresponds to the TUPL1 gene, which has been implicated in DiGeorge syndrome. The green marker, on the other hand, corresponds to the ARSA gene, which acts as a control in this scenario. Note that in the bottom left image, there are two separate red markers and two separate green markers, which is considered normal. In the bottom right image, however, there are two separate green markers but only one red marker. The absence of the second copy of the TUPL gene confirms a microdeletion on chromosome 22, and thus the diagnosis of DiGeorge syndrome. The management of DiGeorge syndrome usually starts with supportive therapy, such as treatment of hypocalcemia and age-appropriate vaccinations to prevent infections. A cultured thymic transplant may be curative of immunodeficiency, and patients may undergo surgical correction of craniofacial defects to address problems like the cleft palate, and they may also undergo cardiac surgery to correct any associated cardiac defects. Let's pause the video to consider this question. What are the 5 clinical features seen in patients with DiGeorge syndrome? Remember that the clinical features of DiGeorge syndrome can be remembered with the Catch-22 mnemonic. The mnemonic stands for cleft palate, abnormal facial features, thymic aplasia, cardiac defects, and hypoparathyroidism or hypocalcemia. And the number 22 reminds us that this happens due to a microdeletion on chromosome 22. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the congenital T-cell immunodeficiencies before your exams. Let's conclude this lecture with a multiple-choice question. A newborn boy is being evaluated at the hospital shortly after being born to a 25-year-old mother at 39 weeks gestation via a cesarean delivery for non-reassuring fetal heart sounds. The boy is cyanotic and pulse oximetry shows 82% despite supplemental oxygen therapy. Physical examination is notable for a cleft palate, widely spaced eyes, and a holosystolic blowing murmur on auscultation of the heart. A chest X-ray is obtained and is notable for a boot-shaped heart and an absent thymic shadow. An echocardiogram is ordered. Which of the following laboratory findings would be consistent with the patient's most likely underlying diagnosis? A. Lymphocytosis. B. Hypercalcemia. C. Low serum PTH. D. Low serum TSH. E. High serum IgE. F. High serum PTH. The correct answer is C. Low serum PTH. This is a case of a newborn boy who is being evaluated for non-reassuring fetal heart sounds after being born at 39 weeks gestation via a cesarean delivery. Notably, the boy is cyanotic and has poor oxygenation saturation on pulse oximetry, despite supplemental oxygen therapy. Physical examination is notable for a cleft palate, widely spaced eyes, and a holosystolic blowing murmur, which, in combination with his cyanosis, that is refractory to supplemental oxygen, is strongly suggestive of a congenital heart defect. Moreover, his chest X-ray is notable for a boot-shaped heart, which is often seen in patients with tetralogy of Fallot, and an absent thymic shadow, which should normally be present in newborns. The combination of a cleft palate, the widely spaced eyes, a likely congenital heart defect, and an absent thymus is strongly suggestive of DiGeorge syndrome as the underlying diagnosis. Recall from this slide that patients with DiGeorge syndrome often have a cleft palate, abnormal facial features, thymic aplasia, cardiac defects, and hypoparathyroidism. The question stem described the first 4 manifestations, and the students were tasked with correctly identifying the last manifestation, which is hypoparathyroidism. Recall from this slide that patients with DiGeorge syndrome often have low serum PTH and calcium as a result of congenital hypoparathyroidism. This is why option C, low serum PTH, is the correct answer. Option A, lymphocytosis, is incorrect because patients with DiGeorge syndrome will likely experience lymphopenia due to a maldeveloped thymus. Option B, hypercalcemia, is incorrect because hypoparathyroidism seen in patients with DiGeorge syndrome will lead to a hypocalcemia, not hypercalcemia. Option D, low serum TSH, is incorrect because thyroid issues are not commonly part of DiGeorge syndrome. Option E, high serum IgE, is incorrect because this is usually characteristic of Job syndrome, not DiGeorge syndrome. And lastly, option F, high serum PTH, is incorrect because patients with DiGeorge syndrome experience hypoparathyroidism, not hyperparathyroidism. This concludes our lecture on congenital T-cell immunodeficiencies.